Justice Health and Alcohol and Drug Services in the ACT. She's recently presented at the South Australian ONA Study Day, and she's going to be doing a session for us this evening on substance use and the orthopaedic patients. So thanks very much, Jen, for coming, and I'll pass it over to you now.
Terrific, and thanks very much, and thanks for this opportunity. Like you mentioned, I first met Paul and the Orthopaedic Nurses Association when I was at the University of Adelaide, and I'm thrilled to be presenting at the forum. And this presentation is pretty much based on what I presented um, because they thought it was useful to sort of look at some of the challenges that can present when people use substances and then some sort of orthopedic situation with specialists.
Hey, sorry, Jen, I'll just get you to come a little bit closer again because we're not hearing you clearly at the moment.
Is that better?
Thank you. Yep, that's better. Thank you.
Okay, so like I said, similar to the presentation that I gave at the South Australian Orthopaedic Nurses Forum, and I don't want to start off on a negative with this slide, but that was sort of the focus of their forum was like when things go wrong and what can you do in your practice of orthopaedic nurses about managing and preventing orthopaedic complications related to things to do with substance misuse, because as many people are probably aware, when people are using drugs or alcohol of some description, things can go wrong. So the best way to do that tonight was through a case study, and also we'll look at some of the latest data from the Drug and Alcohol National Household Survey, which really gives us a snapshot about what's happening in Australia and with drug use at the moment. Anytime throughout, if you've got a question, um, Wendy, you can speak to me, but everyone else, if you just want to write your message in the type box, and I'll be watching that as I go, and I'll address those as I go. So please feel free to interrupt any time. So let's have a look at a real-time scenario, and this one I'd like to introduce Edith. Now, Jen is real-time, so where are we? We're Tuesday night in a little bit before behind people, depending on where you're ringing in from, but around the 7:30 mark. And Edith was admitted on Sunday following a fall, and she fractured her femur. She's currently requiring a level 1, which we also call A category, depending on which state you're in as well. And her relatives and friends are very concerned about her. So I think most people would have nursed someone like Edith in their time. Very confused, hard to manage, and putting herself and others at risk. So what happened? If we look back through her notes, we can see that, before her admission, she was a 78-year-old self-caring lady, no documentation of any events immediately prior to the fall, and the medical officer assessment states that she was a social drinker. Now, a lot of people might think about that and how often that term is used, but how it doesn't really give us much insight into actually how much Edith was drinking at that time. Think about social drinker as well, that some people might be very social and at Christmas or something. So that's a very broad term. So when we dig a bit deeper, we can find that the actual facts or could have been contributing to the fall is the fact that Edith consumes an equivalent of about 6 to 8 standard drinks every day. So just to recap on what a standard drink is, if people were able to answer at this very moment in time, I'd be posing that as a question, but I won't be. So just think of a standard drink as just 10 grams of alcohol. It is, well, we've got Edith there. She's a wine drinker, so it's just 100 mils of wine, um, 60 mils of fortified wines, say your ports and sherries, 30 mils of spirit, and a schooner here of light beer and a midi, so a small one of full strength. So just a reminder there on standard drinks. Also, a bit of a reminder here at the moment about what the low risk drinking guidelines are. So, to stay within the low risk of harm from your drinking is no more than 2 standard drinks per day and no more than 4 on any one occasion. So, you can see here that Edith is drinking way above the low risk drinking guidelines. And once again, if we ask more questions, we can find out that the fall occurred at her grandson's wedding after consuming what she described as a few more than usual. So we can sort of start to visualize there or imagine or piece together how many drinks Edith actually had on that day. So what we're seeing now on the ward is Edith, and she's gone into what we call an unanticipated alcohol withdrawal. Okay, so without that firm history of how much she was drinking, and without alcohol now, she's showing signs of withdrawal. As I mentioned before, she's now at risk of of injury to herself or others. There is already a prolonged length of hospital admission, extreme stress on the family and friends who may or may not know, how much she drinks and what could be occurring. Very resource intensive when you think about having to special Edith during this time when she's so confused, and very much a stretch on staffing resources as well. So this is a real example of when things can go wrong from when you were sort of would expect to be a sort of routine admission for a fractured femur. So it's really stresses the importance of asking people about what drugs and substances they use. When you identify that, being aware that this person may show signs of withdrawal from that substance. But just to put it into a bit of perspective, how common is this? How likely is something like this? Um, how likely is this to occur on an award that you could be working on? So to have a look at this, it's a bit sort of busy this slide, but it's really important. Now this is recent um, data that's come out of the 2010 household survey that you can see there, and what you can see is 80%, just look at alcohol for now. So in this survey, it said 80% of people, have drink alcohol. So this is a snapshot of Australia, and so we can pretty much draw from this that 80% of the Australian population basically drink. Now, this doesn't show exactly how much people are drinking, but when asked the question in the past 12 months, have you drunk alcohol, 80% of the people surveyed over 14 said yes. To look at that a bit closer, particularly when we're looking at this age range of the over 70s. So it's another point as well that we often think that, alcohol in particular is a young person's, um, problem, so to speak. But I think this is really interesting when we look at the biggest daily drinkers are actually the over 70s. Okay, so 14, close to 15% of people over 70 said that they drank daily. Once again, I'd like to stress it doesn't say how much they're drinking. However, just the fact that they are drinking, and a lot of people over 70 are on other medications or might have some mobility issues anyway. To think about the combination of alcohol with any existing conditions or alcohol use. So there's been a couple of trends in both alcohol and other substance use, which I think is really worth identifying at the moment. So you'll be looking out when you're working with your client. The first one's around tobacco. Okay, so I thought as Australians, we can say that we're doing some really good work when it comes to tobacco. And we can see here there's been a significant decline between 2010 and 2013 when it comes to smoking. We're from 15% down to 12%. And I know from a national perspective, the aim is by 2020 to get that number down into single figures. Okay, so well and truly on their way there. And think about some of the things that might have contributed to that when we're looking at changing any sort of culture or use of a substance. They have to address 3 key issues, and that's might be take too long. Yeah, awkward. Um, access, affordability, and exposure. So when you think about what they've done in the tobacco field, is that they've really cut back on access. So the places that you can buy cigarettes have been reduced. The places that you can smoke has been drastically reduced as well. And I know here in the ACT they're also looking at perhaps banning it from, sort of picnic areas and everything like that as well. That even though it's outdoor, it's still public. So access is right as well. Also, with affordability, they found if you up the price, people are less likely to initiate or continue using, and that's been very much the case with tobacco use as well. With I think most cigarettes over the $20 mark now for a for a pack, and also exposure. So they found that the more people are exposed to some sort of substance, when you think back about tobacco advertising, that now all that has been pretty much banned, and sponsorship of sport. So you're just not so exposed and aware of people smoking as well. So just to go over those again, access, affordability, exposure have really worked in the tobacco space, and we're seeing great reduction. When we look at alcohol, there's also been some changes since 2013 and 2010. Um, we're seeing that 18.2% exceeded the lifetime risk, okay, in 2013 compared to 20% in 2010. So there's been some minor changes there. When we're thinking about lifetime risk, that's defined as what I was mentioning before, having more than 2 standard drinks per day. Okay, so they're saying if you have more than 2 standard drinks per day, your lifetime risk of having some sort of harm from alcohol increases. So as a nation, we've dropped a little bit, but we've got a long way to go. Also, we've had some, minor decline in the people exceeding single occasion risk. So, like I mentioned before, single occasion risk is defined as more than 4 standard drinks on occasion. So, some good news in that point is reducing, but still we're over a quarter of Australians drinking more than 4 standard drinks on any occasion. Some good news though with younger people, with 12 to 17-year-olds drinking alcohol, or a higher proportion abstaining from alcohol. So we can see there from 2010, 64% said they were abstaining from alcohol, and 2013, 72%. So there is some positive movement there as well, that people are starting to drink that early. Just onto the illicit drug use, and I think these are the key points from the latest survey. I've just picked out ones that are sort of in the media a fair bit, just to sort of clarify a few things. We saw a slight decline in the use of some illegal substances, including ecstasy. So, and once again, look at the numbers. That's 3% of the Australian population. Okay, so people might be thinking, oh yeah, ecstasy use is a big problem. When we really drill down compared to alcohol, granted that's a legal substance compared to ecstasy, which is still only sort of small-ish numbers of the whole Australian community. Once again, the overall heroin use, 0.2% to 0.1%, and GHB, once again, is really small numbers as well. Where there was a significant increase, though, which might not be a surprise to anyone listening to this, is the misuse of like prescribed or pharmaceuticals, so prescribed painkillers and um, sedative-like substances. So, 4.2% up to 4.7%. And I know in our sector, we're really concerned about this shift and this growing trend. Also, one that's been in the media quite a lot lately as well is methamphetamine use. And the key point here is probably the bottom point. So even though there was no significant increase in the people using it, there was a change in the main form of methamphetamine. I'll just go with methamphetamine now. Use. Now, this is significant because when we think about the presentations to the emergency department, we're seeing a lot. Well, significantly, we feel like there's a lot more people presenting with sort of psychosis-like symptoms and drug-induced psychosis from methamphetamine. And the main reason for this is most people now are smoking it as opposed to using a powder form. Okay, so when people use like crystal methamphetamine, they smoke it or inhale it, they get a much more sudden um, uh, impact of the drug, and they might not be aware. This is one of the key things that happens. They might not be aware of the powerful or the potency of the drug, and therefore they're smoking it. They might smoke more than they think that they normally would or have used before, and that's why we're seeing more presence of psychotic-like symptoms. So that's just something to be mindful of. So we've heard about, well, what's the situation? We've seen a case of Edith about how someone can present and end up in unanticipated substance withdrawal. So now we might move on now about what you can do, how you can manage, well, and more importantly, how you can prevent complications. Has anyone got any questions that you might want to just type in there quickly uh, before I just move on to the managing and prevention? Take that as a no. I'm hoping people are still doing it. And we'll just move on. So we'll look at managing and prevention now. And one of the key things is about asking the question. Really, can't stress enough the importance of actually asking someone about their substance use. And one of the ways you can do this is by using the ASSIST, which is the Alcohol Smoking and Substance Involvement Screening Test. Now, this was developed by the World Health Organization. It started development back in around 97, and it has been modified, and we have version 3.1 now, which is very easy to use. It's an 8-item questionnaire, and it only takes about 10 minutes to administer. And it's been shown that with a targeted linked brief intervention, it's been able to reduce or even, some people may stop using substances. And as a flow-on effect from that, reduces the um, substance-related harms as well. So what's good too, or what's a little bit different about the ASSIST is that it screens for at least 10 substances. So if you think about some of the other screening tools that are available, and they're all, all quite good screening tools, they might just focus on one substance, and just the one that really springs to mind, of course, is the audit, which is used widely for alcohol use. Or, there might be just one screening for tobacco. But if you can ask the questions that cover all these substances, it's, well, A, better at identification, and B, also less cumbersome on the client as well. You might notice down the bottom here it's got other. Okay, so you can see that it covers off on all the main type of substances that you would expect. But if you're in a region that for some reason has, uh, you know, a substance that's not listed here, say like kava or something like that, you can just easily add that in. Or some places that I've worked too have been really interested in people's caffeine use. Okay, so they might, really ask about that or informants for drugs as well. As you can see here, it starts off by asking people about their lifetime use of drugs, but then really focuses on the last 3 months. There's a couple of reasons for that. One is you want to see, well, what's happening right now? What are the possible chances of this person going into withdrawal or showing effects? The other point too is that you think about your own memory. How good are you remembering at anything beyond 3 months? So just to sort of be able to capture that picture that's quite relevant and doesn't go beyond what the memory. One of the key questions that they ask towards the end when we start thinking about, are there signs of dependency, is this one about, has anyone ever expressed concern about your use? And have you had any attempts to either control or cut down but failed? So we want to need, well, we really need that information when we're sort of planning for, treatment planning, and also thinking even at this early stage about relapse prevention. After the questions, a score is calculated and the people are placed into either one of these three risk categories. So low risk. So basically that is saying that the level that they're using at the moment is just putting them at low risk for any harm in the immediate future or long term. The second one is moderate risk, and in any sort of primary healthcare setting, this is the group that most people will fall into. Okay, so I'll just leave that for a moment. I'll just talk briefly about, oh no, actually I'll stick with that. We'll talk about the moderate risk. So this would pick up people who say might be binge drinking, using any type of illicit drug within the last 3 months, and also smoking as well. So they're at moderate risk of harm to themselves in the short and long term. For people in this category, we provide feedback on their scores, so just raising their awareness about some of the possible harms that could be already occurring or may occur in the future. And our real focus then is on a brief intervention. Okay, so this is a skill using some motivational interviewing principles that raises awareness, sort of develops a bit of discrepancy within the person as well about, well, how their current use, even though they might be enjoying it, what could be some of the consequences, and sort of weighing that up and sort of creating some ambivalence in the person. The main aim of this, as I'm saying, is to raise that awareness and ambivalence and sort of lead or um, encourage that person to look at their behaviour and change. So we're sort of planting the seed. If you think too rough, just quickly about the stages of change model, that most people presenting once again in the primary healthcare setting will probably be in the pre-contemplation stage, meaning they haven't given much thought to either quitting or cutting down their substance use. So for a lot of people, it might be the first time that they've sort of um, addressed their use, and the fact that they haven't been asking or they haven't presented asking for this information can be tricky because they might be a little bit resistant, but it's just about presenting that information in a non-judgmental. People that come in the high risk group, they'll actually be showing signs of dependence at this stage. The assist will be able to pick up based on their answers that they've got, they're showing some signs of dependence and could really benefit from a specialist referral or being referred off to specialist treatment to do a thorough assessment. Now, at this stage too, we also provide the feedback and tell them which risk category group they are in. And we still do a brief intervention, but the focus of brief intervention is to encourage that person to go off and have that specialist assessment. Because if you just sort of gave feedback and said you need to go to, this, that A, it would be, and secondly, you want that person to sort of be engaged and want to sort of seek further assistance. So research has shown that focusing the brief intervention on the referral process and avenues to do that is the most effective. So probably at this time you're thinking, oh, well, what happened to Edith? We'll be happy to know that someone did contact the drug and alcohol team when they realised that Edith was actually drinking the amount she was. She was then put on alcohol withdrawal scale and was able to be medicated with Valium, which is the, the drug of choice for managing alcohol withdrawal. And she went through that extremely well. She was able to get all the care and management she needed. And she also worked with the Drug and Alcohol Service for support and follow-up following her discharge, which I believe that she's been attending to very well, and her family has been involved as well. But just on finishing up, if you want to find out more about the assist tool and screening and brief intervention, there's a couple of ways you can do that. The DASA website, which I put the actual link there, so sorry about that, but if you type in DASA into your search and have a look there and put in assist, you'll go to the tools there. There's also online training that's available via the assist Moodle site there, and there's a couple of options there. You can either just learn more about the assist, There's 4 modules, and if you're looking for CBD points, um, they're worth about 3 hours per module, and there's also more study available if you want to sort of do train the trainer or anything like that. So that's available. Face-to-face training's available too. If you'd like to contact me, I can put you signed up for that. And there's also the Assist with Substance DVD and information manual that's been specifically made for nurses that I'd be more than happy to share with you as well and get you linked in with. So that's for me now. There's all my contact details. Like I said, more than happy to have any emails or phone calls or any questions if anyone busting.
Okay, I'll start from Leanne or Mariana if they have any questions for Jen, please.
Okay, that's a really good question. Thanks, Leanne. So the question is, are people mostly honest when answering? I'll answer that in a roundabout way. We've found that if people if there's trust within that relationship, yes. Okay, so and that can be a bit hard to establish sometime in clinical settings, like I said before too. If they're presenting problems, or if they're not presenting to you to talk about their drug and alcohol use. So what we've found has been really helpful is if you explain clearly why you're asking the questions. Okay, so something like the assist, I would be saying, in a any type of clinical setting, I'd be explaining why we were doing it, and that would be along the lines of this is universal screening, that we are asking everyone these questions, and it will just help with the management, and we'll just look at some opportunities and just establish that right at the beginning. People are often, well, as you could imagine, some of the barriers to them telling the truth would be if the substance is illegal, I'm saying there. So once again, if they're not sure why you're asking this, there's, they're suspicious for any reason. They might not tell you about their illicit drug use. Sometimes people can be embarrassed, shamed if they think that they're drinking a lot and they may be judged. So it's very important to have that non-judgmental attitude. And what we've found as well with the assist is if you just ask it as part of a routine sort of assessment or screening like you would for diabetes or falls or anything, just sort of like, oh, and I've got to ask you these questions as well. So I think in a nutshell, if people can establish trust, be non-judgmental, and explain why you're doing it, I find that most people will be honest when. Also, think about the situation as well. That you're somewhere quiet, that people can ask, answer questions confidently, and not sort of open wood with everyone listening. I hope that helps. Another question: do you find you get much resistance from high-risk groups to accept help? Yeah, that's another really good question. I'll answer that twofold. People who present to our service wanting help in that high-risk group, yes, they're very open. Like they're not resistant at all. They've come there for a reason, and we are there to help. So that's great. That they're fun. The ones that we might find resistant are people who have been sent to our service. So there might be a variety of reasons why people are sent to a drug and alcohol service. One that's sort of springing to mind is under probation and parole conditions. They say, part of your probation and parole is that you receive drug and alcohol counselling. Now, people that can be quite resistant, but we find, well, I find that, even if they've stepped through, there's hope. So we will engage with, I spend a lot of time in those initial stages just building that rapport and working out, well, what can we do on together, and it's very important to push people to listen. And I think they're sort of the best skills to sort of get through that resistance and, basically say what we can offer and try and find some sort of middle ground there. It can be tough, but I feel like, you can develop the skills to sort of get more information out of that person and sort of work with that resistance. Hope that helps. Okay, so just really question. Sometimes these coaches, so yeah, play one staff member off against the other. Any tips? Yeah, look, that's a really good point. Even people with substance misuse issues and sometimes without as well. We can, just some of the mental health background I have with people with sometimes borderline personality disorders and start staff. And some of the good tips that I've used on units, because sometimes it can be very subtle, you don't even realise it's happening, and then it's sort of all of a sudden you get some problems with staff and relationships that way. So one of the things that we do with withdrawal units is just be very consistent. Okay, so rules for one, you don't break any rules. And these could be little subtle rules, like, there's rules about the times that you can use the phone or times for breaks. Not stretching those sort of boundaries at all, and everyone needs to be consistent because we've found too, particularly with introduction of, say, no smoking rules or policy within the hospital setting, if one staff member says, "Oh, well, you can come out and have a CBC," it just dissolves the rest of the framework for other people coming into following them. So if people are a bit more predisposed to sort of splitting type actions, it's just so important for staff to be consistent. So I think that's the number one. And the other thing too is for staff to communicate. If they're starting to feel like there is people are being played off against each other, to call it. Like during handover, and just for people to be aware of that, and it might be just that reminder about being consistent again as well. Does that help at all? Right.
Okay, so do we have any other questions? We've just got typing happening at the moment.
Thanks. I hope that helps. And I'm more than happy for you to ring me or contact me if you want more information offline as well.
Oh, that's great. Yeah, well, thanks very much for that, Jen. We also get some of our members will watch the webinar at a later time as well. So that's really, really handy that you've put your contact details up on that last slide, because if they have any questions as well, we'll encourage them to contact you too. But thank you so much for presenting, and thanks for everybody that's come. And I'll click off the end of the session now, and we'll be back in touch with you another time, Jen. So thank you.
Terrific. Thanks very much.
Thank you.